And now I would like to open the floor for Mr. Gary Howe, Ernst & Young Healthcare Group. And the topic of the presentation is Sustainable Healthcare for Europe in the 21st Century.
I actually don't have any slides. Good afternoon, everyone. So obviously for the people looking at the screen at the far side, do try and watch me over here. But I am only 5'5.5", and when I have lecterns like this in front of me, then many of the audience often can't see me. And when you are only 5'5.5", you realise just how important half an inch can actually be. I hope you can hear me okay. I'm intending to try and just give lots and lots of examples of actual pieces of work you can go look at to demonstrate those organisations delivering really great pieces of work in the space of sustainability. I've spent 24 years of my life supporting providers in looking at issues of viability, in looking at sustainability, in looking at cost reduction. Unfortunately, in the last 3 years, increasingly I'm working with organisations who are very much in distress. Organisations with huge financial deficits. And usually organisations with big financial deficits also have clinical problems as well. Peter mentioned earlier one of our organisations in the UK that for the first time has been put into formal administration. A private sector organisation is now running that organisation, and indeed that organisation is Ernst & Young. They had a major clinical failing, 1,000 avoidable deaths in 3 years. They also had a huge financial problem. And our government has intervened to try and address the issues facing that particular hospital. But they are not the only one. And all across the globe, I see health systems where individual organisations are in deep distress. In Canada, in the US, some of the very, very big names in the US, for the first time, big providers, names we would all recognise, losing money. And commercial private sector organisations don't lose money for long. So a solution will have to be found. There's some great work in the Netherlands, in Sweden, really great examples of organisations delivering transformative work. Interestingly, in all of those organisations, when we're asked to go support our clients, usually there are two questions we're wrestling with. One is, do you want us to help you do everything you currently do for the least amount of money? Or are you trying to find what you will be able to do with the amount of money you have available to you? And those are two very different questions. And I'm sure eventually every government across the EU will have to address the second point. Eventually we will have to say, what does a health system stand for? What should it do? We've already heard this afternoon a number of interventions of limited clinical value for the patient. Should we continue doing those things? And I think every government eventually will have to face that second question. And indeed, the debate in the UK is already happening about what can the UK government afford to provide as part of its health system. But we don't have to be there yet. And I'm massively optimistic and enthusiastic about the prospect for health, simply because we still waste huge amounts of resource in the delivery of healthcare across the EU and indeed across the globe. We probably only operate at something like 70% of our real capacity. Healthcare providers are wasting resource on industrial scale, and they don't need to. The fixes are easy. There is an opportunity available to us now. And I would like to share some examples to try and give some of the points, bring some of those points alive, because clearly they're fairly bold statements. I'll start with an example in York. I was at a conference in York 2 weeks ago. York have been, they're in the north of England, for those of you not familiar with the UK geography, I do apologise. York is a high-performing foundation trust in the UK. In fact, last year it was the highest-performing foundation trust in the UK, and it brought together a group of 500 doctors across North Yorkshire and East Yorkshire, a large geographical area, some 500 doctors in the room, and the medical director stood up and said, we will face, and are facing indeed, the same financial pressures across the rest of the UK, but we can fix the problem ourselves. We do not need to do some of the dramatic things that other organisations are having to do. We can solve our problems in this health community ourselves. Why? He said, we actually harm between 1 in 7 and 1 in 10 of every patient that comes into our health system. And we then have to fix the harm we do to those individuals. At any one point in time, we have 250 patients in beds who shouldn't be there. The variation in referral by primary care physicians, the variation in referral from one physician to another across their patch for the same presenting condition is 5-fold. So in his clinic alone, he said, I see from some GPs large volumes of patients I don't need to see. And that variation we can fix. We as clinicians can stop that. We can use our resources so much better. Theatre utilisation across Europe runs at something like 70%. There's a fantastic example in the Netherlands. If you go to Almelo and Hengelo, a number of years ago in the Netherlands, they had very, very poor access rates, like some of the ones you saw earlier from Peter. Patients had to wait a long time for elective surgery. They also had very, very high costs, and they were becoming unsustainable in financial terms. The doctors got together and introduced a system they refer to as tactical planning. And tactical planning was simply doctors managing themselves. They introduced a process where every 2 weeks, each individual consultant's performance was analysed, and the question was asked, did you use the resource we gave you? Did you use your beds? Did you maximise the use of your outpatient clinic? Did you actually use the theatre session that we gave to you? And if you didn't, why not? And every 3 months, they run a big event at which, if individuals have not utilised the capacity, it's taken off them. And the surgeon or the physician then has to earn the right to get it back. Utilisation in theatre went from 70% to 96%. Waiting times went down from over 6 months to 6 days, and they saved €8 million. My colleagues are working on a piece of work in Oslo as we speak, and they have increased outpatient productivity in Oslo twofold. 100% improvement in outpatient productivity in a major hospital in Oslo, simply by ensuring there's good discipline, good governance, regular review of performance. It's transformed the outpatient service. Doctors now have more time with their patients. A fantastic example in the United States recently, I was with the Surgeon General for the Navy, Admiral Nathan. They introduced a pilot scheme a year ago to monitor patients using smart technology post-operatively. So these were people with surgery being monitored by use of the telephone and use of smart TVs in their own home. And the outcome measures against a control group were dramatically improved simply by calling the patient once a day post-operatively, or even having a teleconference, video conference with them in their own home. But they also noticed a really dramatic difference as they extended the pilot. The volume of primary care attendances dropped by 50%. Patients felt empowered. The public felt empowered not to have to go see their GP anymore. It's had a huge impact on the capacity in primary care. There are lots and lots more examples. I was in Canada recently talking about radiology, and we were working with the healthcare provider and said, can you show us how you translate your demand for main X-ray into the resource you use to maintain your X-ray department? And they said, yes, it's very, very simple. Each X-ray takes 15 minutes. At peak periods, we have this many X-rays, therefore we need that many radiographers. And that's how we staff the department. We examined with them what happened in the 15 minutes, and every X-ray only took 6 minutes. Their effective capacity was 2.5 times that they were constraining themselves. They could have dramatically improved the throughput in radiology at no additional cost, or indeed could have reduced the cost quite dramatically. A number of other examples. In a European Renal Centre, we examined the cost of the renal service, it was very, very high compared to other benchmarks. And in particular, drug spend in this renal centre were very, very high. The spend particularly on EPO, epoetin, which maintains the red blood count and can delay the point at which patients have to go on to dialysis. And they had 35 patients who couldn't go into dialysis, needed dialysis, but couldn't go into dialysis, not because there wasn't dialysis capacity, but because they didn't have capacity in their theatre to have the shunts fitted to provide the vascular access to put patients into dialysis. When we got the health system to pay for the theatres to be opened for the weekend, and the volume of epoetin prescribing went down, the net effect to the health system was patients were being treated properly, and therefore their lives were much enhanced. But the total cost went down €350,000 overnight for that health system. These are just a few and may appear trivial examples, but every single organisation I work in have exactly the same issues. We're all facing exactly the same problems, and the potential for improvement in the delivery of healthcare, in primary care, in secondary care, really is massive. And it's an opportunity we could all take now. Across the EU, we have a fantastic opportunity to share some of these experiences and actually drive improvements with very little investment. We don't need policy reform. We don't need permission. We don't need incentives or innovation. We could make a huge difference now. And let's face it, sustainability is a function of two things. It's a function of effectively using all the resource we actually have available to us, and at the same time then deciding what healthcare should actually stand for and what it should provide. One of the big debates in that space we have in the UK right now, and I'm sure everyone else has it too, is we treat literally tens of thousands of frail elderly patients in hospitals because there's nowhere else to put them. But that's not what a healthcare system should be there for. We need to provide alternative provisions to treat that cohorts of patients, and we can. And it would be a better solution for everyone if we did. And the healthcare resource we would have available to us would be significantly improved and utilised better if we dealt with those issues. So what is it that in these, there are many, many organisations who do these things and do them well, but the vast majority of still don't. Imperial College Hospital has been a client of mine for years. They were in serious financial distress 18 months ago, and in 18 months saved £100 million. They have a turnover of just over £1 billion. And in 18 months they saved recurringly, annually, efficiency improvement of £100 million. And they're not unique. They really are not unique. Most healthcare providers we work in, there are one or two exceptions. The German model is very, very productive, and elements of the Swedish model are very good. But the vast majority do have this opportunity available to them. The one thing that really makes a difference is leadership. And it's organisational leadership. It's not policy leadership. It's organisational leadership. Our exiting chief executive in the NHS in England, Sir David Nicholson, said organisations need to look out, not up. Don't look at the policymakers. Don't look at the strategists. Look around you. The inspiration is out there. I would actually add to that by saying also look within. Eliminate the variation within, and the opportunity is immense. If, for example, you analyse for every single DRG the length of stay for every individual consultant treating the same condition, it's a very, very simple analysis, and then you calculate if every single physician got their length of stay up to the average of their own colleagues. And interestingly, we heard in one of the sessions earlier an example about Manchester being a very deprived part of the UK and being an area where you're more likely to die from cancer. That organisation in Manchester has been a client of mine for a long time, so I'm hoping that none of their problems are related to the work that we've been doing with them. But they used to have 2,100 beds. When they did the calculation I've just described, they needed 750 fewer beds to treat the same group of patients. 750 fewer. Today they have 1,450 beds, and they're treating more patients. and that just by eliminating that variation within, if we can then really draw on best practice across the UK and then across Europe, just think how big that potential would be. So leadership is critical, but it's organisational leadership. We don't need permission. I don't think we need policy reform. There isn't a magic bullet, a silver bullet that's going to slay the vampire and make health suddenly better for us. Organisations can do this for themselves. But there are three other important enablers, and then I will finish. The first is every time we have reorganised health systems, they get more expensive, and the outcome goes down for a while. Stability would be good. Organisational stability, policy stability would help, because we can then focus on the providers of healthcare, and we don't have to focus on whether we have a job in a year's time. So certainly stability would help. Policymakers and administrators can also help with incentives. There are some really perverse incentives across healthcare across Europe for people to treat patients the wrong way. We have incentives in the UK for our clinicians that actually incentivise clinicians not to treat many patients in the NHS, because if they treated a lot of patients in the NHS, they'd have no private work to do, and they make all their money from their private work. Well, that just can't make sense. And there are a whole series of other incentives of that type across healthcare systems that could be fixed relatively easily. So certainly taking away some of those unusual incentives can help. And I think the third thing, and the most important one, that philosophy of relentless delivery. It is all about the execution. We've heard many times over the course of the last day and a half that the policies are clear. We know what to do. How many times have we heard that over the course of the conference? We know what to do. So surely then we have to just do it, to steal an expression from a very well-known manufacturer of sportswear. But I think that mindset of relentless delivery, let's just do it, let's execute, let's make this happen, is what distinguishes the really good organisations from the ones who haven't yet got there. And at that point, I'm happy to end. Thank you.